Welcome and thank you for joining this Medtronic webinar. My name is Megan Stevenson, Medical Education for Asia Pacific. We're delighted to be able to bring to you this popular topic, managing challenging meals. This presentation was pre-recorded so that we could bring to you live a quality audio-visual production. After the presentation, there'll be live Q&A, and I encourage you to post your questions in the chat box that's provided, either below me or to the right of me. Now I'd like to introduce you to our speaker, Dr Carmel Smart. Carmel has worked as a specialist diabetes dietitian at the John Hunter Children's Hospital for over 25 years. She holds appointments at the University of Newcastle and the Hunter Medical Research Institute. She's led national and international clinical practice guidelines in the dietary management of diabetes and is co-author of the ADA Medical Nutrition Therapy Handbook. Carmel is regularly invited as a plenary speaker across Australia and internationally to frontline clinicians and families. Thank you, Carmel.
Thank you so much, Megan. It's a great pleasure to be here on this virtual presentation to discuss managing challenging meals. In this presentation, I will talk about the impact of fat and protein on blood glucose levels in people with type 1 diabetes, and then identify strategies for insulin dosing for protein and fat for different insulin therapies, including the new hybrid closed-loop therapies. The carbohydrate counting method for mealtime insulin dose calculation has been shown to be an effective strategy for HbA1c reduction and improved quality of life. However, as we all know, it's not a perfect method. Evidence from the literature has demonstrated that postprandial hypoglycemia remains a major issue, with one study in children and adolescents demonstrating 45% of meals consumed by children failed to meet postprandial targets despite accurate carbohydrate counting. There is now a growing body of evidence that recognises the significant contribution of dietary macronutrients to postprandial glycemia. Our research and the research of others has demonstrated that both fat and protein result in delayed hypoglycemia. Clinical guidelines, including the recent American Diabetes Association guidelines and the International Society of Pediatric and Adolescent guidelines, recommend dosing for fat and protein for added glycemic benefit after carbohydrate counting is perfected. In our recent commentary in Diabetes Care, we identified that there is a need for an evidence-based, safe, and practical method to guide insulin adjustments for high-fat, high-protein meals. The mechanisms by which all three macronutrients impact blood glucose levels in people with type 1 diabetes is shown in this figure. However, the increased availability of continuous glucose monitoring has also heightened, importantly, the awareness of people living with type 1 diabetes as to the different impacts of food. And what they really want and are demanding from health professionals is a way to keep their blood glucose levels in target whilst they consume a different variety of foods. This is also the case and is seen in hybrid closed-loop auto mode, where the impact of high-fat and high-protein meals can be observed. Further than that, very high carbohydrate meals in auto mode also cause unexpected glycemic excursions. In order to come up with strategies for fat and protein dosing, we really need to think about three really important questions. Number one is, what is the impact of fat and protein when it's consumed with carbohydrate? Number two is, what is the impact of fat and protein when consumed alone? And number three, what amount of fat and protein starts to require insulin? In our initial paper that we published in this area back in 2013, we looked at the separate and combined effects of fat and protein, all with the same carbohydrate amount, on postprandial glycemia, and this was in children and adolescents using both multiple daily injection therapy and pump therapy. We found at 5 hours that the mean glycemic excursion from the high-fat, high-protein meal, containing 35 grams of fat and 40 grams of protein, resulted in a millimole excursion of 5 millimoles higher than the low-fat, low protein meal, and this was despite accurate carbohydrate counting. We then examined the impact of increasing amounts of protein with a set amount of carbohydrate in children and adults using intensive insulin therapy. Between 30 to 60 minutes, we found a dose-response trend towards lower postprandial excursions with increasing amounts of protein. Conversely, between 3 to 5 hours, we found a significant dose-response trend towards higher postprandial excursions with increasing amounts of protein. So was this effect the same if a meal with protein but no carbohydrate was eaten? In our next study, we aim to determine the effects of protein alone. And this study was done again with both children and adults. And it can translate into the higher protein, lower carb meals that we see commonly consumed by people now. What we found in this study was that the protein-only meals had no significant impact in the first 2 hours after the meal was consumed. However, the very large protein amounts from 50 grams upwards resulted in raised glucose levels commencing at 3 hours and continuing to 5 hours after the meal, with a mean difference of 2 millimoles, similar to the impact of 20 grams of carbohydrate, which has not been given insulin for. So in summary from those studies that we did, for most adults, the impact of dietary protein commences at 30 to 40 grams of protein in a meal, or more than 50 grams of protein alone when eaten without carbohydrate. Protein added to a meal dampens the glycemic rise, and protein with carbohydrate may help prevent late post-meal hypoglycemia. If we then consider the impact of dietary fat, like protein, fat reduces early postprandial excursions. It also increases delayed hyperglycemia. And importantly, and the jury is still really out on this one, the types of fat may have different impacts. 2 studies have recently added to this evidence. We can be informed by the quantities of fat and of protein that were used by these studies to determine the impact on extra insulin needs. Bell in her study reported an additional 20 to 60 grams of fat required more insulin, and Gringas found 35 to 35 grams of protein also required additional insulin, and these indeed supported the results of previous studies. In summary then, on average for most adults, additional insulin is needed for food containing more than 30 grams of fat and more than 40 grams of protein. So if we now reflect, is additional insulin needed for these 2 different foods? If we first look at 40 grams of mixed nuts or 260 gram T-bone steak. From what we've just discussed, 40 grams of mixed nuts only contains 8 grams of protein and thus would not require additional insulin. However, a large T-bone steak, one that you will often get in restaurants, will contain up to 75 grams of protein and thus helps explain why people with type 1 diabetes will often report exaggerated delayed hyperglycemia after eating these foods, and they do require additional insulin. If we then move on to fat, if you eat 1 sausage within a meal, does that require additional insulin as opposed to 2 sausages within a meal? And what we know is that from the studies that we've done and others, 17 grams of fat in most people does not require additional insulin, whereas 35 grams of fat does. At the John Hunter Children's Hospital, we've translated these into resource sheets for our patients, and there has been a large uptake, and I think that that's really been promoted by the fact that the majority of children in our clinic are now using continuous glucose monitoring. What we particularly found during the COVID pandemic is that children really started to routinely use continuous glucose monitoring to enable us to adjust their insulin remotely. So with these sheets, you will notice that the protein and carb and fat amounts are smaller, and that's simply because we are talking about children. So what we did when we developed these sheets were actually take sub-analyses of the studies that we'd looked at, and we found that in children, generally, we're looking at more than 20 grams of fat and more than 30 grams of protein, slightly smaller than the amounts that you would see for adults. But that would be expected, because an 8-year-old child weighs a lot less than a 30-year-old man. So there are two really important questions that remain to be answered, and where currently a lot of research is occurring. The first of those questions is how much additional insulin is needed for fat and protein. And the second question is, once you arrive at that insulin dose, how and when should this be delivered? If we look at those two previous studies we spoke about earlier, Kirsty Bell and her group found that there was an additional 6% of the carbohydrate dose was required for meals containing 20 and 40 grams of fat. An additional 20% of the carbohydrate dose was required for meals containing 60 grams of fat. Gringus actually found an additional 39, so in fact 40% insulin was required for meals containing 35 grams of fat and 35 grams of protein. What was important to note with both of these studies, though, was that there was inter-individual variation. So when we're talking to people with diabetes, we can certainly start with average figures, but this needs to be titrated clearly to the individual experience. In this study, which we've just presented at ISPAD at the end of last year, what we found was that an additional 40% of the mealtime insulin dose was required for high-fat, high-protein meals. And again, titration was necessary based on the individual child's response. However, the 40% dose was tolerated on average by most children and resulted in optimal postprandial glycemia. Another study, which we've just published in Diabetic Medicine, showed that an additional 30% was required for the carbohydrate dose for a high protein meal. So how should this additional insulin be delivered? In a study that we published in Diabetic Medicine in 2017, what we found was that at least 60% of the dose of a combination bolus needs to be delivered up front. And in many people, actually, they tolerated 70% better up front. This was also supported by recent findings from Bell, where they found at least 60% again of the dose needed to be up front, ranging up to almost 80% of the dose up front. New data from this study showed the optimal duration of the bolus dose changes depending on the amount of fat in the meal. So in summary, what should you do when you're seeing a patient and they need advice around fat and protein dosing and delivery? Firstly, what we're saying is add additional 20 to 40% to the carbohydrate dose. And for most people, it's best to start conservatively so that you're doing an additional 20% initially. You then titrate that on an individual basis. It's important to use the dual wave bolus, providing 60 to 70% of that total dose up front, and then deliver that, according to the individual, over 2 to 3 hours. And there are a number of studies that you can see on the screen that support this. So now if we move on to the 670G, what insulin dosing strategies for fat and protein do we need to consider when a person is in manual mode versus when a person is in auto mode? What we know is that fat and protein do impact in auto mode. And really what we're asked by our patients is, what do you advise? And should we be giving more insulin? And how should we be splitting this insulin? Because as we all know, in auto mode, the dual wave bolus is not available. So in auto mode, what strategies do we have to manage meals that are high protein, high fat? Currently, there are no studies. However, we are presently undertaking a study both in children and adults to look at these strategies. Clinically, though, many people have been asking for advice over the past year, and what I'm going to speak to you about now are some of the strategies that we currently suggest in clinical practice. So firstly, we still suggest that you add additional insulin to the carbohydrate dose, starting with 20% and increasing that as needed up to 30%. We don't go right up to 40% because we do find in auto mode that the basal dose starts to ramp up. Secondly, the suggestion is, as there is no dual wave option, to give 60% of this dose before and 40% at 1 hour. And you can see on the slide that I've translated this into a meal. So if a person's eating 50 grams of carbohydrate, they would need a fat protein supplement of 15 grams of additional carbohydrate that they dose for. And that's based on adding 30% of the insulin dose that they would normally give for carbohydrate. They would then split that to 39 grams of carbohydrate before and 26 grams at 1 hour. As you can imagine, that's quite a lot of maths for a person with diabetes having to do. So what we've done in our clinic is we've developed 2 cards, one for an additional 20% dose and one for an additional 30% dose. And the one that I've highlighted here is the additional 30% dose. So if we just hark back to that meal, the person eating 50 grams of carbohydrate would dial up an additional 15 grams of carbohydrate for the fat protein supplement and bolus 65 grams of carbohydrate, splitting that as 40 and 25 grams at 1 hour. So let's practice that. What bolus strategy would you use for this meal in auto mode? And people with type 1 diabetes, I'm sure you've all had this experience, will often say that fish and chips is very difficult, and often in our experience in Newcastle will send their child high all evening. So what we're going to do here is we're going to first add 20% more insulin to the carbohydrate dose. So with this particular meal, that would be 60 grams of carbohydrate plus an additional 12 grams fat and protein supplement up to 72 grams of carb. Then using one of our cards for our 20% dose, what they would do is give 45 grams of that carb before and an additional 30 grams of carb at 1 hour. If we then look at a high protein meal that does not contain carbohydrate, what we found in the studies that we did with Megan Patterson was that you do need additional insulin up to the equivalent of 10 to 15 grams of carbohydrate. So you start with that and then increase that on an individual basis. So if you had a person that was eating no carbohydrate at a meal and just having a meal that was high in fat and protein, the advice is to give the equivalent of 15 grams of carbohydrate and to provide that immediately before eating, not 10 to 15 minutes before, but straight before eating, and again increase that on an individual basis. If we then look at the impact of a high carbohydrate meal in auto mode, I work with adolescent boys, and what you can find is that they might eat up to 100 grams of carb, perhaps even 120 grams of carbohydrate at a meal. A common experience from this is that they'll first dip, sometimes even experiencing close to hypoglycemia, and then go very high afterwards. So what strategy would you advise here? More insulin or a split dose? Currently, what we're suggesting is that you split the dose. So you first check the carbohydrate counting accuracy, and then you provide 80% of the dose before and 20% at 1 hour. In this particular meal, what that would mean is giving 80 grams of carb before and 20 grams of carb at 1 hour. So this is just a summary table that just reflects on what we've just discussed. And I'm going to focus on the auto mode part of the summary table. With a high fat, high protein meal with carb, add additional 20 to 30% to the carbohydrate dose and give 60% of this total dose before the meal and 40% at 1 hour. In a high protein meal without carb, start with the equivalent of 15 grams of carb immediately before the meal. And with a very high carbohydrate meal, and by that I mean a meal that's 100 grams of carbohydrate or more, still provide the insulin 15 minutes before, but give 80% of the insulin dose before and 20% at 1 hour. The other really important point when you're in auto mode is that bolus behaviours matter. So these slides demonstrate firstly hypo overtreatment and secondly postprandial dosing. What's really important with hypos are that people don't overtreat hypos, and indeed with younger children we've found 7 grams of carbohydrate is sufficient to treat a hypo. With older children, and adults, making sure that you're limiting that to 10 to 15 grams of carbohydrate. And the other critically important point is to dose 15 minutes before. If you dose afterwards, you're actually increasing your risk of hypoglycemia. For many children and adults, that's been a major difference, but certainly the rewards have been large when they've learnt to dose 10 to 15 minutes before. So the key takeaways, and if we just focus first on the happy ticks, is encouraging bolus 15 minutes before food, treating hypos with 10 to 15 grams of carb, checking with the person their carbohydrate counting accuracy. And as we all know, that's not easy. So if you're eating out, it is tricky, and really checking with people the different varieties of foods that are available and how much carbohydrates in those. Optimizing their insulin to carbohydrate ratio. The fat and the protein side of things only start to count once the insulin to carbohydrate ratio is optimized. And then step 3 is considering the additional insulin for high fat, high protein meals. As we all know, working with people with type 1 diabetes, it's so important to individualize. And remember, if habitual dietary intake changes such that they might commence a high-fat diet or perhaps start including more carbohydrate in their diet, the ICR first needs to be reviewed. Things that you should avoid when you're starting someone on insulin pump therapy or the 670G is bolusing after food and avoiding overtreating hypoglycemia. The other important point is not encouraging continuous snacking and skipping of meals. And, no one can do that whether or not they have diabetes. So it's really important to encourage as far as possible some sort of meal structure, particularly in this time when a lot of people are at home and perhaps snacking more than they normally would have. Also avoiding high carbohydrate loads at meal times, really avoiding fake carb entry to correct rapidly rising blood glucose levels. And finally, I really want to make the point strongly, when you're adding the additional insulin in, it needs to be calculated as a percentage of the meal insulin only, not including the correction insulin. So if we now consider 2 case studies. So I'm just going to talk you through 2 young men and some of the issues that they had, and then how we resolved those. So the first one is Matthew. Matthew is now at home because he can't go to school because of COVID. And so what he started having time to do is actually eating bacon and eggs for breakfast. However, he's on the 670G and he's not bolusing for those because there are no carbs. But he's now frustrated by the glucose rise and associated alarms, and he really wants some help. So based on what we've just talked about, Matthew would first give insulin for 15 grams of carbohydrate, and then what he found was that that entry wasn't sufficient. So we actually took him up to 30 grams of carbohydrate for protein and fat. And as you can see on this slide, it really improved his postprandial glucose profile. And the other thing that happened was that the basal no longer attempted to cover the meal. So as a result of that, Matthew now is very happy, and happily for Matthew's mother, he's now resumed school. The second case study is Nick. So with Nick, what we observed with Nick is a pattern where he would enter his blood glucose and he'd calibrate for breakfast, but then many people, busy people, he forgot to bolus for breakfast. Auto mode did its job and it increased the basal to deal with the glucose rise. Nick then remembered that he needed to bolus, and so what he did was he bolused 30 minutes later, but coupled with that increased basal, and the dose for the food, it then resulted in a surplus of insulin, which resulted in him having hypoglycemia. So what to do for him? What the suggestion is first is to remind Nick to pre-bolus 10 to 15 minutes before the meal. And if it's less than 1 hour when he remembers to bolus, enter only half the amount of carbs because the basal dose will have started to ramp up. If it's greater than 1 hour since the meal, enter the BG and do a correction dose. With Nick, he then decided to have 2 pizzas for dinner. And what he found was a typical response where you get the high fat, high protein rise. And what many people with diabetes find frustrating about this is that they might have a dinner. Most people wouldn't eat 2 pizzas, but this is a young guy after a busy day at school. What he did was he found that he then needed to give a correction bolus at 8 and then another correction bolus at 10:30. So what strategy would you recommend for him? Basically, the strategies that we could use are a split bolus, so giving a 60-40% bolus, and adding into that the fat protein supplement, so an additional 20% of insulin. Alternatively, he could exit auto mode to use the dual wave, but most people prefer to stay, in my experience, in auto mode, and so splitting that bolus and adding that additional insulin is really helpful. Okay, so now Nick decides to eat 1 pizza. He was too full after having 2 pizzas. And so what he does is he does his normal bolus at 7 o'clock, but again is woken by alarms at 11:30. And this is really annoying him. He does want to continue to eat pizza now and then. And so what strategy as a health professional would you recommend based on the discussions we've had? Can you please enter your responses in the Q&A chat box, because that will help others see what potential strategies we could be suggesting to Nick. Now, for me, what I would recommend is adding a supplement for fat and protein, and approximately a 20% supplement to start with, and then splitting the bolus 60% given 15 minutes prior to eating, and 40% at the 1 to 1.5 hours mark. But I'm very interested to hear back about your responses and the things that the wider audience would have suggested. So I just want to thank you for your participation in this virtual presentation. I want to thank Medtronic for inviting me to discuss our studies and also our new studies that we'll be conducting. And I wanted to thank our wonderful research team at the John Hunter Children's Hospital and the fantastic and most importantly, the children and adolescents and adults that we work with who do the studies with us and help us take diabetes care one step further. Thank you. And now I'm very happy to take questions. Please enter the questions via the Q&A chat box and we'll try to get through as many of those as we can. Now over to you, Megan.
Thanks, Carmel. These are really helpful strategies, and I'm sure there's a lot of healthcare professionals in attendance tonight that are thinking of patients that they might be able to use these strategies to help them manage these kind of foods.
I hope so, Megan.
Thanks to the audience also for all of the great questions. We've been looking at them as we have gone through this session, and hopefully we'll be able to answer most of these questions. If you don't get your question answered, please make sure that you reach out to your local representative. So for the first question, I'd like to ask Carmel. Many patients do not know how to calculate out fat and protein. Do you have any suggestions for this?
Yeah, no, that's a really good question, and thank you to those who asked that. Basically, the first thing that's really important to do is to refresh carbohydrate counting, because in doing that, what that then enables you to do is to identify fat and protein-rich meals too. So that makes it easier for the person with type 1 diabetes to identify where they might be looking at to dose. It's then necessary to identify foods that are high protein and high fat. And typically, as discussed, that would be foods that contain more than about 30 grams of fat and more than about 40 grams of protein in an adult. When we look at our children data, it's typically more than 20 grams of fat in younger children and more than 30 grams of protein in younger children. What's really important to convey, and I think this is something that's tricky for everyone, just like carbohydrate, the weight of the food doesn't translate into a high protein, into the protein content of the food. So for example, eggs are a protein-rich food and they contain only 6 grams of protein per 60-gram egg. So that's a really important concept. The other thing that you could look at doing, and we have considered this in people who really want to know more, is dividing food up into gram estimations. So what we've developed, as you saw, are sheets where we talk about fat, and how we decided to do that was to go with 10 grams of fat, 20 grams of fat, 30 grams of fat, and 40 grams of fat. People aren't then counting exact estimates, but it does give them a ballpark in which to start for looking at high-fat foods. And the same with protein. Instead of counting grams of protein, we say to people, if you're thinking about protein, a 15-gram estimation, and then a 30-gram estimation, and then a 45-gram estimation with columns on those foods is a good place to start. There are some really good videos or resources that are available. So one of those is Food Talk by Trudy Williams, and you can look at that online, and she does some nice protein resources. There are other ones from the UK, Carbs and Cows. They have protein resources as well. And they also have, as part of their number of different resources, fat resources. So there are resources available, but it's really important to engage a dietitian who can actually translate what the person's eating into protein and fat quantities.
That's really good to know. Thanks, Carmel. The next question is, I have patients with type 1 diabetes that are choosing to be on a keto diet or a low carb diet. What suggestions do you have for the management of these patients?
Yeah, no, that's really important. So what I'll focus on here is actually, firstly, what a keto diet means, because I think sometimes in the literature, it's really confusing as to what keto means as opposed to what low carb means. So a keto diet typically is less than 20 to 50 grams of carbohydrate a day in an adult. In a child, obviously, because their energy needs are different, that is a different amount depending on the age and the activity level of the child. So the other important point to make about keto diets when you're talking about children is that you're looking at less than 10% of energy coming from carbohydrate. With a low carbohydrate diet, it's typically less than 26% energy from carbohydrate. So most studies on people with type 1 diabetes indicate in general that they eat somewhere between 40 to 45% energy from carb. A low carb diet is typically less than 26% energy from carbohydrate, or in an adult, less than 130 grams a day. And that's sort of a starting point when you're seeing someone that you might want to think about what they're actually pursuing. What's important there is to bolus in an adult for fat and protein, and in a child following a lower carbohydrate diet for fat and protein, because what's really important is that they have enough bolus insulin. Typically, we would suggest that they bolus just before, as I discussed with individual meals. And for example, if they were having 50 grams of protein, they would start with 15 grams of carbohydrate. And that figure has actually been backed up just by another recent paper. So there are a number of papers. We certainly found that with Megan Patterson's study, but there are a number of papers that also continue to back up that figure in the literature. I think the other important thing to realise is obviously this is individual. So whilst we are fairly conservatively starting with 50 grams of protein is equivalent to about 15 grams of carbohydrate, for some people, they will then need a larger dose. And certainly for some children who are having a very low carb breakfast, As we've talked about, we might end up giving 30 grams of carbohydrate that they dial in for the fat and the protein. The other important thing to consider with low carbohydrate diets and very low carbohydrate diets when you're talking to people is also a more holistic view, as you would do with anyone that you see with type 1 diabetes. You would consider their lipids, you would consider their growth if they're a child. You would also consider things like calcium, fibre intakes, and other micronutrient intakes. So all of those are necessary to consider as well.
Oh, great. Are there any differences between fat and protein type?
Well, Megan, that's a really good question, and thanks to those who asked that. With fat and protein type has not yet been studied in the literature, and there's no published studies on it that I'm aware of. Fat type has been, and the findings have been equivocal. So Kirsty Bell's group in Sydney, they've looked at fat type and found no difference in fat type in terms of bolusing. However, Bozzetto has found differences in fat type. So I think what might be important to consider there is the habitual diet of the person and whether or not the insulin, how much fat the insulin to carbohydrate ratio is covering and what typical amounts of fat they have in their diet and whether it's saturated fat or monounsaturated fat that they're typically eating.
That's great. Thanks, Carmel. What about MDI? If a healthcare professional has patients that are not on pump therapy, you get the bolus all up front. How do you do this?
Yeah, and that's another really good question. So thanks for asking that too. These are great questions, actually. So with multiple daily injections, there aren't many studies on this, and we're currently submitting a study to ISPAD, and I won't go a great deal of detail into those results because it's unpublished data. But I think what's important to say here is that our patients, the people that I work with, the kids that I work with, have told us that they give the additional insulin up front, and some of them do see trends going down on their CGM, but they don't hypo, and then it later controls well the postprandial rise. Certainly in the study, and well, I won't go into the details of that, but I think it substantiates that response from the children. There is only one other study that has been published, and that additional dose was given 30 minutes later. So that's, 3 hours later, not 30 minutes later, 3 hours later. So it was more like a correction dose. So I think what's important there to make a point about is that there may be some people who do require the dose to be split. Certainly that hasn't been borne out by our clinical experience, nor indeed in our study. However, I do acknowledge that there is individuals that may require that additional bolus at 1 hour after the meal. And obviously, with people with type 1 diabetes, one big thing about fat and protein dosing and also about split dosing is that we really need to make sure that that works for the individual. And so we start with these as a general starting point and then titrate and individualise that to the person based on either blood glucose monitoring or CGM findings.
Great. Thanks, Carmel. This has been a great opportunity to hear about different kinds of foods and strategies that we might be able to apply for better management of these challenging meals. If you came in late to this webinar or would like to watch this webinar again, this recording of this session will be made available on our healthcare professional website. If you just go to the webinars tab, you will be able to view the recording of this session. And also there will be a short summary video available as well. In addition, we've actually put together a summary guide that will be available in the resources tab. So as we close this webinar and this session, I'd really like to thank Dr. Carmel Smart and you, the audience, for attending this webinar. And I'd really love it if you could provide us with some feedback. There is a link below if you click on the link, and give us your feedback, because we really want to improve what we do. So thank you, everyone, and enjoy the rest of your day.
And thank you, everyone, and thanks, Megan.